Hi, so this lecture is going to be on calcium regulation and pituitary physiology. Okay, so an overview of calcium, a few things. First off, in the plasma, the concentrations of free ionic calcium is typically in the order of about 50 milliequivalents per liter, or sometimes you'll see it written in the clinical labs as 10 milligrams per deciliter. So that would be our normal concentrations. Now, about 50% of the calcium is actually bound to proteins, and the proteins like albumin, for example. Now, another interesting property of this calcium binding to proteins is the fact that it actually competes with protons or hydrogen ions for the same binding sites on proteins, which means that the level of protons or the level of calcium can increase or decrease depending upon the pH of the blood. So as an example, in an acidotic state, where you would have more protons in the blood, the increase in protons in the blood, which would lower your pH, making you acidotic, would actually help to outcompete calcium binding on the proteins. So therefore, more protons would bind to the proteins, and that would release more calcium into the plasma, therefore increasing free calcium plasma concentrations. The reverse is true too. So if you're in an alkalotic state, during alkalosis, your pH is increasing because the number of protons in your blood has decreased. And so therefore, there's a decreased amount of protons to compete off the calcium, and so more calcium can actually bind to the proteins. And so therefore, the free plasma concentrations of calcium decreases with alkalosis. Clinically, you might see a scenario like this when somebody is hyperventilating. When they hyperventilate, they blow off a lot of CO2. And CO2, as it's decreasing, causes a change in the pH of the blood. And that's based on that relationship that we've talked about before, where CO2 and water combine to make carbonic acid, which then splits into bicarbonate and a proton. And so when the CO2 levels start to decrease, that shifts the equation so the protons bind to bicarb, and so the proton level decreases and your pH goes up. And so this can cause changes in calcium binding to protein. And so more calcium will bind to protein, and then your calcium level will start to decrease. So we'll talk more to that in a few more slides, actually. And then lastly, the relationship between calcium and phosphates. So in fact, there's a relationship here, an equilibrium, that is useful to know. So let me just get my pen here. All right, so we have a relationship with calcium and phosphate. So I have calcium, 2 plus, let's say we take our phosphate, HPO4, 2 minus, and we'll have an equilibrium. All right, so we have an equilibrium where calcium is bound to phosphate, HPO4. And so this equilibrium is between the blood plasma and the bone. So for instance, if let's say there was a decrease in the phosphate level in the blood, that would cause the calcium phosphate on the bone, that equilibrium, to shift in this direction, so that it would actually increase the level or replace the level of the lost phosphate. Now, if calcium level is already normal, that would actually increase calcium levels above normal. So there's that relationship. And of course, that works both ways. If calcium levels were to drop and phosphate levels started out normally, then the phosphate levels could rise above normal. So there is this relationship between the two. And I'm going to come back to that because this is going to be one of the ways in which we can regulate calcium levels, is by altering the amount of phosphate that's in the blood. Okay. Just, some of the physiologic roles. This is kind of like looking at a broad picture of calcium. Some of the main things that it can do in our body is contribute to the hardness of the bones itself. Kind of gives it that ceramic hardness, which helps to support our body weight and structure. Clotting, so blood clotting. Nerve signaling, like we need calcium to release neurotransmitters, or the vesicles to fuse and release neurotransmitter to signal. Muscle contraction, right? So we need calcium to actually get a good contraction in both skeletal, cardiac, and smooth muscle. Some general features of bones. So here I just want to talk a little bit about the anatomy of bones, because that is where the biggest storage of calcium is in our bodies. All right, so we're going to have over 1,000 grams of calcium stored on the bones. So there's compact bone, which usually makes up the dense outer shell of bone. And then internal to that, you're going to have spongy bone. And so the spongy bone, so I'll pull it here. All right, so there's the spongy bone, which is in this area here. Okay, you can see that on the picture. And it's also referred to as cancellous bone, all right, or trabecular. And it's more loosely organized, not as compact. And you'll usually see it at the center of the bones, or on either end of long bones, you'll see an abundance of that. Okay, so this example down here in the bottom left picture. All right, you can see that spongy bone there. And then, of course, that would be covered by the more durable compact bone. So it sort of surrounds the spongy bone. And spongy bone, again, has these little spaces. It's a little more porous, which would be, sites for cell synthesis of like red blood cells, white blood cells, megakaryocytes making platelets. And that would be the red bone marrow, for example. And in the yellow bone marrow, you might see things like adipose tissue. The types of bone cells that we'll see are generally 4 types. We have the osteogenic cells, the osteoblasts, the osteocytes, and then the osteoclasts. All right. Now, before I go into any further description on those types of cells, understand that bone is actually a connective tissue type. So it's sort of on one of the extreme ends. We have blood, which would be a fluid type of connective tissue. And then you have bone, which is a very hard type of connective tissue. And it's going to have cells and fibers and ground substance and so on. So the 4 types of bone cells, we're going to start with the osteoprogenitor cells, or otherwise known as the osteogenic cells. And these are the bone stem cells that are able to differentiate into other types of cells, namely the osteoblasts. The osteoblasts are mainly known for their function of actually building up the bone or laying down that bony matrix. So they'll be producing the extracellular proteins like collagen and hyaluronic acid. And they'll also be secreting some of the salt components or the ionic components like the calcium and the phosphates that will bind to those extracellular proteins and give it more of its hardness. Now, when the osteoblasts are actually building up bone and encasing themselves or enshrining themselves around with all this bony matrix, they will ultimately turn into or mature into osteocytes. And then the osteocytes will ultimately just maintain the bony material, the bony matrix that it's surrounded in. And it'll send off little processes to actually communicate with other osteocytes who've also been sort of enshrined in bony matrix. And it's also a way for them to communicate and ultimately to get nutrients that they're going to need, considering that they're surrounded in a very hard matrix. So this way a blood supply, whenever it delivers nutrients, can go from cell to cell. And then finally there's the osteoclasts, but the osteoclasts are from a different lineage, from like a white blood cell lineage, like macrophages, like monocytes, macrophages, and so on. And so the osteoclasts, their main job is to break down the bony matrix. And so breaking down the bony matrix and ultimately dissolving those salts and releasing them into the plasma, that's referred to as resorption. So that's the term used when breaking down that bony matrix. Now, you can see in this cartoon here, we have an osteoprogenitor cell, ultimately comes an osteoblast, which builds up the bone. And then you can see it even changes conformation, becomes mature, and becomes an osteocyte when it's essentially surrounded by its bony matrix. And these little processes will actually communicate with other osteocytes. A different lineage is the osteoclasts. And so you see that over here. These are very large cells. And you can see this sort of ruffled border on the bottom there where it kind of essentially just chews up the bone and in a process we call resorption, where it dissolves some of that bony matrix and then can release some of the salts into the water, into the plasma, so they can release things like calcium and phosphates into the plasma. So it can help us regulate those levels. And so there's actually an equilibrium that we're going to talk about between bone buildup and bone breakdown. And it's kind of important to understand that bone is not inert. but in fact it's actually very dynamic, and under normal circumstances is in an equilibrium between bone breakdown and bone buildup, or bone resorption and bone building. So again, the bone's a connective tissue, all right? And so the extracellular matrix is primarily composed of water. It has minerals, complex salts, and the main complex salt is actually something called hydroxyapatite. And that is actually bound to structures or proteins in the extracellular matrix called collagen. So there's two characteristics to bone. One is its hardness, which is dependent on the inorganic salts. So the calcium phosphates, the calcium hydroxide, that hydroxyapatite, they give bone the hardness that they have. Okay, and then the second component to the bone is flexibility. We don't generally think of bones as being flexible, but in point of fact, it's actually a requirement to make sure that the bones aren't too brittle. And so the flexibility is contributed by organic molecules. And so that would be things like collagen and the extracellular proteins that are secreted by things like the osteoblasts. And so it's this composite of, or balance I should say, between hardness and flexibility that makes up the bone. All right. And so an example I like to give for that is if you take a bone, all right, and if you were to bake the bone, all right, if you bake the bone, you can actually denature a lot of the organic molecules, and you're left with the inorganic salts. So you have more of the inorganic salts relative to the organic molecules, and the bone becomes very brittle, and it's actually very easy to snap. Okay, I mean the bone is still hard, but it just breaks very easily. And then on the other hand, if you took bone, and instead of putting it in the oven, you put it, let's say you bathed it in vinegar for a little while. Well, the vinegar will actually start to dissolve a lot of the inorganic salts, but it won't affect the organic molecules. And so what happens is, if you try to break the bone there, it's not brittle anymore, but it bends, it's more flexible. And that's because you've dissolved off the inorganic salts. So those experiments are kind of interesting, and it helps to kind of paint the picture of the balance between the hardness and the flexibility. There are other minerals included in the bone, as well as calcium and phosphates, which we talked about. Things like magnesium, potassium, and fluoride that you would see in the teeth, for example. So by dry weight, the bone is about 1/3 organic and about 2/3 inorganic material. Again, that organic material is going to be collagen or carbohydrate-based proteins, like glycosaminoglycans, proteoglycans, and glycoproteins. And then the inorganic material, which we've mentioned, about hydroxyapatite, about 85% or so. That's crystallized calcium phosphate salts, and 10% calcium carbonate, which is something you might see in stone. So it adds again to the hardness of bone. And then those other minerals that I've mentioned before. Bone is a composite material. Again, now instead of looking at it as sort of organic and inorganic material, like the salts and the polymers, sometimes it's described as sort of a ceramic and a polymer, where the ceramic really represents the inorganic material, the salts, like hydroxyapatite, and the polymer represents the proteins, which gives the flexibility. And so there's actually clinically disorders where we have an imbalance between the ceramic or the polymer portion. So for instance, if you have a lack of the inorganic salts, say due to something like vitamin D deficiency, which you can see in some parts of the world, you'd say that could be a childhood disorder. We would call that rickets. So rickets, it's a disease caused by mineral deficiency, and the bones end up being softer and more easily deformed. On the other hand, it could have something like osteogenesis imperfecta, and that's called, another name for that is called brittle bone disease, and that actually results from a defect in the collagen deposition. So in that case, you still have the inorganic salts, but you're lacking the collagen, so it becomes more brittle. Similar to if you were baking the bone in the oven, right? You're baking off the polymer and leaving behind the inorganic salts, excuse me. This picture here is just to kind of emphasize and demonstrate here in some countries where if there's a vitamin D deficiency and they are lacking mineralization on their bone, so they're lacking the inorganic salts. You can see here just the abnormal bending and curvature, the lordosis here in the spine. The bones just become much more flexible, and so you can see gravity kind of takes over and bends them. And in the cartoon over here, you can see that kind of flex or bend to the bone as well. And this is, again, this is really one of the reasons it could be like vitamin D deficiency. And you can see here just that sort of that curvature, all right? In terms of hormonal regulation of calcium metabolism, you can see here in this cartoon, all right, and over here, this other bone. If we have bone formation, so again, that's osteoblastic activity. All right, so let's draw here. So we have the osteoblasts over here. They would be building up the bone. So it'll be thickening it and strengthening it, laying down more bony matrix. And then that's in balance with osteoclastic activity, which is right down here, the osteoclasts, which are resorbing the bone or breaking it down. And so under normal circumstances, we have a balance between how much gets built up versus how much gets broken down, and it's typically even, okay? And so there's some things that can affect that balance, and these are normal physiologic responses to either increase or decrease building up or breaking down of the bone. So let's take a look at some examples. Let's take a look at the osteoclastic activity. So this would take bone and it would resorb or break down some of the minerals and redistribute it to the blood. So parathyroid hormone over here and vitamin D. So what parathyroid hormone does is it's actually a hormone that's secreted by the parathyroid glands located on the backside of the thyroid gland. And parathyroid hormone actually increases in response to low levels of plasma calcium. And so in response to that, parathyroid hormone levels increase, and parathyroid then acts on the bone and the osteoclasts to increase resorption. So that way it can take calcium off the bone and it can distribute that to the blood and then raise the calcium levels that way. And parathyroid hormone, in addition to doing that, has multiple other actions, which we'll get to, but one of them is initiating vitamin D synthesis and secretion from the kidneys. And vitamin D then will act synergistically with parathyroid hormone in helping to increase blood calcium levels. However, on this side, opposing that is calcitonin. Calcitonin actually increases in response to high levels of calcium in the blood, and so therefore it tones down the calcium level. All right. In other words, it lowers the calcium level and it stimulates more osteoblastic activity to distribute more calcium to the bone. Estrogen would also inhibit bone resorption. And so estrogen can actually decrease the number of parathyroid hormone receptors on the bone. And so therefore it becomes less responsive to the parathyroid hormone, therefore less likely to undergo bone resorption. On the flip side here, if we're to try to increase bony formation with the osteoblasts, all right, we have, so here are the osteoblasts here, so we're building bone up. To stimulate that, all right, we'd have over here, right here, all right, so mechanical stress. Mechanical stress actually stimulates bony formation, so they've actually shown studies where impact exercises and things of that nature can actually increase bony deposition. And so it's sort of the body's way of responding to the demand that it's under. Okay, so the bones will actually strengthen when used, and so they'll build up and become bigger and stronger. Androgens, which we're talking about things like testosterone, for example, can also increase bone formation, and we'll come back to that in a later lecture. Here, all right, inhibiting bony formation would be the opposite of mechanical stress or exercise, would be immobilization. So bedridden patients who've been lying down in bed for prolonged periods of time, who don't get much exercise, the body has an incredible way of sort of adapting to the need. And so if you're not going to use it, you're ultimately going to lose it. So the bone will get resorbed and they'll use these parts and recycle them for something else instead. Aging, you see a decrease in bone formation as we age. And then, of course, a low calcium diet could also inhibit bone formation. So this is the parathyroid glands, which, as I mentioned before, are located on the posterior aspect. All right, over here and here, as you can see, 4 glands here, located on the posterior aspect of the thyroid gland. And so their job is really to sense changes in calcium levels in the blood. And so they'll increase extracellular fluid calcium concentrations, and they're stimulated by that low calcium concentration. So parathyroid hormone starts to get released when there's low calcium. And the parathyroid glands, again, like I said, there's usually about 4 of them embedded in the posterior surface. They secrete the parathyroid hormone, and in addition to what I said, which was stimulating resorption from the bone, which will ultimately increase calcium levels by basically taking it right off the bone, but it'll also promote renal synthesis of calcitriol, which, let me see if I can highlight that for you here. So here's calcitriol. So it converts vitamin D to its active vitamin D form, which is going to again act synergistically with the parathyroid hormone and increasing calcium levels. It's going to increase renal reabsorption of calcium. So it increases the reabsorption so we don't lose that or excrete that calcium in the urine. And then it will increase renal excretion of phosphate. Now, that may seem a little odd at this point, but if you guys remember the relationship between phosphates, okay, and calcium, then it should seem somewhat clearer. So let's see if I can remind you guys quickly. Right, then we have calcium plus the phosphates, all right, are in equilibrium with each other here. So this is on this side, what I'm drawing now, HPO4, is on the bone. And so if I excrete the phosphate in the urine, then I'm lowering the overall phosphate concentration, and so I'm going to shift the equilibrium in this direction, and that will ultimately result in an increase in my calcium levels. So I'm doing several things here. I'm taking it off the bone, I'm reabsorbing calcium from the kidney, I'm activating vitamin D to help out, and then finally I'm going to excrete phosphates, which will ultimately help me shift that equilibrium in favor of increasing calcium levels. So vitamin D, so how does it actually help and work synergistically with parathyroid hormone? So first, a couple things about vitamin D is that it's a fat-soluble, so it's fat-soluble vitamin. And so it's in the category of one of the A, D, E, and K. Those are the fat-soluble vitamins. And it's actually a vitamin that we can synthesize ourselves from some sunlight. And it's based on a precursor cholesterol. But we can also ingest it. So that's what this cartoon over here is showing. Is you can see, let me change the color here. So you can see that we can get it from UVB exposure. So our skin cells can ultimately convert that cholesterol and convert it into something called D3, which you can see over here, D3. And when we ingest, sometimes from diet, you can see over here we get D2 and D3 from our diet. And usually when we're talking about vitamin D, we're talking about D2 or D3. So it's pretty common to just call it vitamin D. What happens is after initially being induced from, say, sunlight, it goes through an enzymatic pathway in the liver. Or if it's coming from the diet, again, it's going to go through the liver through this enzymatic pathway to ultimately reach the first precursor, which is here, calcidiol. All right, so that's really, it's hydroxylated at the 25 spot here. So we call it 25 hydroxy vitamin D. But that's not active yet, so it has to go to the kidney next. So when it goes to the kidney, the nephron cells will be able to convert that into calcitriol, which, if you look at the name over here, is 125 dihydroxy vitamin D. So it actually added a hydroxyl group here on the 1, which now when it's 125, that's the active form of vitamin D, and so that will assist in regulating calcium. In some cases, you can have an inactive form, which is hydroxylated at the 24 spot, which will just get excreted in the urine. So once it's been converted by the kidneys, now remember the parathyroid hormone can actually induce the release of this activated vitamin D. And so what it's going to do at that point is it's going to increase intestinal reabsorption of calcium and phosphates from the diet. Okay, so under normal circumstances, when we ingest calcium, it's not 100% absorbed in our intestinal tract, maybe 50% or less. So this will actually increase that absorption. It's going to mobilize calcium and phosphate from the bone, so just like we saw with parathyroid hormone. And interestingly, renally, it's going to increase reabsorption of calcium and phosphate, so it helps us to regulate the phosphate a little bit more too. Now, calcitonin would be the antagonistic hormone to parathyroid hormone, and it's located in the parafollicular cells, which are over here. It's up here. So this is a follicle over here. So that's a follicle, but then there's this grouping of cells right here, and those are the parafollicular. So they're located between those follicles within the thyroid gland. So the parathyroid glands were glands embedded on the posterior aspect of the thyroid gland. The parafollicular cells are located in the thyroid gland itself between the follicles of the thyroid. And what they'll do is they'll release calcitonin in response to high levels of calcium. And so their job is to ultimately tone down calcium levels or have it be redistributed to the bone. So now, what happens if there's a change in our calcium levels? So for example, if our calcium levels go too low, what are some things that we might see maybe clinically? So first off, something that might cause low calcium levels would be a deficiency in our parathyroid hormone levels. Or maybe we have renal failure and we're excreting a lot of calcium in our urine. We're unable to sort of reabsorb that calcium. So things you would see would be, all in all, an increase in nervous system excitability. So for example, carpal pedal spasms. So I have here carpal pedal spasms, meaning spasms or contractures of the hand and foot, which you can see in this image over here to the right there with the person's hand there. You would also see maybe CNS changes. And in terms of excitability, if it was very severe, you might even see seizures. You could also see a prolonged, what they call a prolonged QT interval, which we'll be discussing more in the EKG lecture. But just to remind you guys, the QT interval is on an EKG. If you remember, there's a P, QRS, T waves, and they represent atrial and ventricular depolarization and repolarization. The QT interval really represents ventricular depolarization and repolarization. So it's really the amount of time it takes to depolarize and repolarize, and that's our QT interval. And there are various factors that can lengthen the amount of time or shorten the amount of time it takes for it to depolarize and repolarize. So hypocalcemia is one of those factors. A low calcium level would prolong the amount of time it takes for the ventricle to repolarize. And so we call that a prolonged QT. If it takes longer to repolarize, what can happen is you could actually have another action potential that starts before that's fully repolarized. And what ends up happening then is you get something called a torsade de pointe, which is down here, a turning or twisting of the points. And so you get this image down here, all right, which is a dysrhythmia that could ultimately lead to death if not treated very quickly. And as you guys are going to see clinically, that there are a host of other factors that could actually cause that particular phenomenon. Another thing you might see clinically is something called a Schwarzschild sign. And so this has to do again with neuronal excitability when there's low calcium levels. And so the facial nerve, which you could really get sort of the base of the nerve here coming out anterior to the ear, if you were to tap that, okay, tap that nerve on one side of the face there, you could actually elicit twitching of the facial muscles. Of course, you have to remember that the facial nerve innervates the muscles of the face. So when you tap that, you'd see twitching of maybe around the mouth or the eye, which is, by irritating that nerve, it can cause that kind of stimulation, and it's because it's hyperexcitable. And it would happen on one side of the face, on the side that you were tapping. And again, the reason for the excitability really has to do with the fact that low extracellular calcium changes the threshold for voltage-gated channels in neurons. So for example, voltage-gated sodium channels have a certain threshold to fire, let's say, an action potential. Calcium helps to regulate or maintain that threshold. So if the calcium levels are low, the threshold gets lower, meaning it becomes more negative or more easy to reach. So it becomes ultimately more excitable. Hypercalcemia, again, this would be too much calcium. So this could be caused by the hyperparathyroidism, and or tumors that are actually producing a parathyroid hormone-like compound, which you might see in some tumors or some cancers of the lung. Would also cause CNS changes, but typically slower. So instead of hyperexcitability, you might see slowing down of mentation, coma, death, hypotonia, hyporeflexia, and then a short QT interval. So instead of a prolonged one, it would be shorter. Now, if we're talking about parathyroid disorder specifically, in hyperparathyroidism, we have an excess of the parathyroid hormone, which can cause hypercalcemia because it's excessively increasing calcium levels, which could lead to things like renal stones, otherwise known as nephrolithiasis, weakening of bones in some percentage of patients because we're resorbing so much from the bone itself. It can cause abdominal problems. It's been shown to cause things like peptic ulcers, constipation, polyuria, actually. So the polyuria, we have increased calcium, free calcium levels. So in the nephron themselves, tend to attract more water, becomes more osmotic, and can increase the urine output. Increased levels of calcium in the blood can lead to hypertension, more smooth muscle contraction, and again, mental changes, which you can see here. All right. There's something called pseudo hyperparathyroidism. Pseudo means false. All right, so it's not really the parathyroid gland's fault in this particular case. So it's a non-parathyroid tumor that secretes a parathyroid hormone-like compound. The most classic example is squamous cell carcinoma of the lung. So this carcinoma releases a compound that behaves very similar to parathyroid hormone, which will then increase calcium levels and behave very similarly. Hypoparathyroidism would be sort of the opposite problem, where the calcium levels would then be too low. We wouldn't be able to increase calcium levels, and so you'd have inadequate parathyroid hormone, hypocalcemia, and then of course all the hyperexcitability that we talked about. So that would include things like tetany, stiffening and twitching of muscles. And on this slide, this is just to say again that we have a balance between buildup and breakdown, buildup or resorption, and under normal circumstances, that's an equilibrium, which again, depending on what type of lifestyle you're living, it will change and adapt accordingly. But in cases of osteoporosis, we have an offset of that balance, where you end up with more resorption than building up, so the bone becomes more fragile. Okay, so you can actually see it in the osteoporotic bone here, the larger trabeculi and pores here relative to, say, healthier bone. So there'll be medications that you guys will learn more in pharmacology called bisphosphonates, which can inhibit osteoclast activity. So just to remind you, osteoclasts break down bone. They resorb the bone. So if I inhibit the osteoclasts, I can at least inhibit or reduce the amount of resorption that's taking place. Okay, so this is the hypothalamus and the pituitary gland. The hypothalamus forms the floor and the walls of the third ventricle. All right, and basically it regulates primitive functions, things like water balance, which we've discussed in earlier lectures, thermoregulation, so our body temperature, hunger, sleep, sex drive, and childbirth. And so that's kind of a very broad overview of some of its function. So oftentimes when the hypothalamus is signaled, or the receptors are signaled to respond, it'll respond also by signaling the pituitary gland, which is located just posterior to it and connected to it via the infundibulum, which you can see in orange down here. All right, so here's the hypothalamus in blue, the infundibulum in orange, and then you can see this structure below, which is the pituitary gland, which is this green and purple structure. So the pituitary gland is suspended from the hypothalamus by that stalk, the infundibulum. The location, it's actually protected by the bony structure, the sphenoid bone, and there's a little pocket in the sphenoid bone called the sella turcica. And so the pituitary sits in there, and you can see it in the picture over here to the right, which is that little orange knob there, all right, sitting in the sphenoid bone in the sella turcica. So composed of two parts, which is actually the anterior pituitary, otherwise known as the adenohypophysis, which is a gland, and then the neurohypophysis, which is the posterior pituitary, which is technically not a gland, which is just an extension of the central nervous system. So this slide is just really here to demonstrate the point of the origin of the anterior pituitary. So if we're looking at this here, you can see this is the developing nervous system over here, all right, and down here, all right, that is the posterior pituitary, which is the neurohypophysis, and so that's actually part of the neural tissue. And then over here, this is the pharynx over here, this region right here. You can see sort of out pocket. This is the mouth, the opening of the mouth, and this is the tongue over here, just to kind of give us a little orientation. All right, now there's actually budding off from the pharynx here. So it's called the hypophyseal pouch. Oops, sorry about that, but this right here, the hypophyseal pouch, which buds off from the pharynx during development. And then you'll notice that it fuses with the posterior pituitary, which is actually an extension of the central nervous system. So the adenohypophysis actually came from pharyngeal tissue initially and is actually a gland and not directly an extension of the central nervous system. So the way the nervous system then communicates with the anterior pituitary is actually via what we call a portal system. If you recall, a portal system is actually where you have two capillaries linked in a series. So here you can see that we have our main arterioles that lead to the capillaries in the hypothalamus. And then the hypothalamus, these cells here will actually secrete their product into the blood. And then ultimately that will then go into the venules, just like a normal capillary system would, except that these venules lead to another capillary system, or another capillary bed, which is located in the anterior pituitary. So that whatever is secreted by the hypothalamus can kind of go directly to the anterior pituitary and then bathe those cells and communicate with those cells in the anterior pituitary. And so that's referred to as the hypophyseal portal system, which is different than how the posterior communicates with the hypothalamus, because the neuron cell bodies are located in the hypothalamus and they send neural projections directly into the posterior pituitary, which again is an extension of the nervous system. So it doesn't need this portal system. So that's called the hypothalamo-hypophyseal system. So what happens is that'll actually be a spot where the hormones are stored, not produced. So usually the cell bodies in the hypothalamus will make that hormone and then transport it into the posterior pituitary to be stored and wait for a signal to be released. So for the anterior pituitary, we have 6 basic hormones that I'm going to talk about now. And so these hormones, all right, so let's bring it up here. So we're talking about the anterior pituitary. All right, and the way I remember these hormones, by this mnemonic here, flat peg. All right, so flat peg. The F stands for FSH, which is follicle stimulating hormone, and the L is LH for luteinizing hormone. And so this is actually our gonadotropes. So this is our gonadotropes here. So these cells release gonadotropes, which means these FSH and LH are going to stimulate the ovaries and the testes. So for example, follicle stimulating hormone is going to stimulate production of the oocytes, so the follicles, that contain the oocytes in the ovaries, all right, or stimulates the gonads to produce sperm. Whereas luteinizing hormone in the female will induce ovulation. In the male, it helps to produce testosterone. And we're going to talk more about that in the reproductive lectures. Now, A over here is for ACTH, adrenocorticotropic hormone. So adrenocorticotropic hormone, this hormone is going to go to the adrenal gland to release cortisol. And cortisol will have a multitude of actions, which we're going to talk about in a separate lecture. And this T is TSH for thyroid stimulating hormone, which we have discussed before. So that's here on this slide. You can see thyrotropes release that. And that stimulates secretion of thyroid hormone from the thyroid gland to regulate basal metabolic rate. Over here, this is PRL or prolactin. So prolactin, okay, is in the female will actually induce milk production in the mammary glands. And we're actually going to talk more about that again during the reproductive lectures. E stands for endorphins. Excuse me, endorphins. That's an H. Endorphins. All right, so E stands for endorphins. And then G stands for growth hormone. All right, so growth hormone. And we're going to talk about growth hormone today, and as its name implies, it will have to do something with the growth of the body. So here on this slide, what you can see, all right, down here is, or excuse me, over here, the corticotropin cells, all right, release adrenocorticotropic hormone. And so we'll talk about some of that in a different lecture. All right, so it'll be increased during times of stress or hypoglycemia to help raise blood sugar levels. The prolactin, mammotropes, again, because it's going to help produce milk. Okay, and then growth hormone, somatotropes, soma means body. So we'll talk about the effects of growth hormone today. That's going to help stimulate things like mitosis and cellular enlargement, as well as affect our metabolism. And down here in this cartoon, this is just a basic demonstration of a negative feedback loop. We've discussed this when it comes to the thyroid hormone, where it releases TSH from the anterior pituitary. That releases, that signals the thyroid gland to release thyroid hormone, T3 and T4. When the T3 and T4 levels rise, that signals the pituitary gland to inhibit the release of TSH. And so we have a nice sort of negative feedback loop. And you're going to see that often with many of these hormones, but there'll be some exceptions, and we'll talk about that in those lectures. But in this example, you have from the anterior pituitary over here, you're releasing ACTH, or adrenocorticotropic hormone, acts on the adrenal gland to release cortisol. And when cortisol levels rise, that feeds back on the pituitary, also on the hypothalamus, and it inhibits any more release of ACTH. In the posterior pituitary, there's two hormones that are released. So we have the antidiuretic hormone, which we've talked about before in previous lectures. Ultimately, we know that it really does two things. One, it conserves water, right? Because it's an antidiuretic, and so it reabsorbs water from the distal convoluted tubule and collecting duct of the nephron, and it can do that through the V2 receptors. Okay. Another name for it is also vasopressin, because it does have a very potent stimulus to vasoconstrict, and so it can act on the endothelial smooth muscle cells, of the blood vessels, cause vasoconstriction, and it acts on V1 receptors there. And so that will cause vasoconstriction. Both the conservation of water, or reabsorption of water, and vasoconstriction can also help us increase our blood pressure. Oxytocin has a multitude of effects, some of which are sexual arousal and orgasm, stimulates labor contractions of the uterus during childbirth, and stimulates the flow of milk letdown. Not the milk production, that's prolactin, but milk letdown. So it'll squeeze the glands there to help discharge milk, and that's usually the signal for that is stimulation of the nipple, so when the child is nursing. And so we'll come back to that again. The hypothalamic. So we talked about the hormones from the anterior pituitary and posterior pituitary, but in the hypothalamus, so we're in the hypothalamus, We also have other hormones that generally if it's coming from the hypothalamus, they'll have releasing in their name. So, for example, we have TRH. So that's thyroid releasing hormone, which signals the anterior pituitary to release TSH, thyroid stimulating hormone. All right. We also have CRH, corticotropin releasing hormone, to release ACTH from the anterior pituitary. So again, these hypothalamic compounds are going to signal the pituitary gland. Then there is GnRH, which is gonadotropin releasing hormone. So if you remember, the hormones that stimulate the gonads are FSH and LH. So it's stimulating their release from the pituitary. Then there's GHRH, which is growth hormone releasing hormone. All right, so these are all releasing hormones. So you see releasing in the name, you can think hypothalamus. All right, now prolactin is a little bit different. Prolactin is typically under more tonic inhibition. And so there's what they call prolactin inhibiting hormone, which is actually just another term for dopamine. So dopamine actually inhibits the release of prolactin. And then there is somatostatin, which is over here, somatostatin. All right, which actually inhibits growth hormone. So you notice with growth hormone, it's got a sort of more dynamic spread of actions that it has in the body. And so not only does it have a growth hormone releasing hormone, but it also has a growth hormone inhibiting hormone, if you will, or somatostatin. And that helps to kind of regulate its rate of excretion. So this is just a summary, just to kind of demonstrate the effects of the hormones or their destination. So for example, prolactin here. So this is prolactin, acts on mammary glands to produce milk. Here's TSH, acts on the thyroid gland, so I have specific targets. FSH and LH, acting on the gonads. ACTH, acting on the adrenals. And then over here, growth hormone. Growth hormone has much more far-reaching effects on multiple tissues. So one of its primary effects is to actually act on the liver. So it'll go to the liver and it'll produce an intermediate called IGF-1, which we're going to talk about. All right, and that can stimulate growth of things like muscles and adipose tissues, and we'll talk about that. So growth hormone can directly act on tissues, on a multitude of tissues, or it could act through the liver through intermediates. So growth hormone, released from the somatotropic cells in the anterior pituitary. It's one of the most abundant hormones released from the pituitary gland. And so it's released from the anterior pituitary, and it does have a widespread effects on body tissues. So it does have effects on things like cartilage, bone, muscle, and fat. Those seem to be some primary things that it does. And its blood levels do fluctuate. So another thing to mention about these pituitary gland hormones is that many times we refer to them as pulsatile. So it's not kept at one constant level, but it has peaks and troughs throughout the day. And sometimes they follow very distinct patterns, like, for instance, the circadian rhythm. So they might increase or decrease at night, increase or decrease in the morning when during awakening, and then throughout the day have different periods where they'll increase or decrease. And not only will they have that sort of basal level of secretion, but then they could be influenced again by metabolic or active changes in our environment and things that we are doing. So to kind of discuss growth hormone, we have to understand that growth is quite complex and is dictated by many different factors. So the fact that it's multifactorial, some of the things that kind of contribute to that would be things like genetics. So for instance, growth hormone can essentially excuse me, maximize our potential for growth. So the same given amount of growth hormone for one person means that they'll grow to a certain height and maximize their potential, where somebody else could be maybe taller or shorter, even with the same amount of growth hormone. But ultimately, the growth hormone is critical at certain times in our life in order for our certain growth to take place. And when I say growth, I mean not just growth of bones and cartilage, but also obviously muscle, but other organs as well that will grow. And so usually during fetal development and just after birth, growth hormone is not really a part of that growth response. But after a few months after birth, growth hormone is required for the growing that occurs, both in the organs and the skeletal system. And then we need growth hormone again, especially during puberty, when we have our growth spurt. And it kind of works in conjunction with the thyroid hormone. In fact, thyroid hormone can stimulate the increased release of growth hormone. So they do work together. So in other words, if thyroid hormone is reduced, then growth hormone would also be reduced. And so thyroid hormone and growth hormone together work synergistically during that growth spurt period during puberty. So in addition to the growth effects that it has, it's obviously going to be affecting metabolism. And so when we talk about metabolism, we categorize it a little bit, its effects a little bit like insulin or anti-insulin effect. So for example, it does have insulin-like effects. And what I mean by insulin-like, if you think about what insulin does, it lowers blood glucose levels, which drives it into cells. But more generically than that, what it's doing, insulin is actually increasing anabolic reactions. So the building up of things, right? So when we increase uptake of glucose, we'll use that for energy. Yes, some of that's going to be catabolic for sure, but we'll also be producing glycogen. Okay, we'll be undergoing protein synthesis, lipogenesis, producing triacylglycerols and such. So there's a lot of this anabolic kind of reactions when insulin levels are high. And so in accordance with that, growth hormone is insulin-like because it can enhance the uptake of amino acids. All right, and especially on skeletal muscle. So it'll enhance the actions by increasing amino acids and reducing protein breakdown, and therefore helping to increase protein buildup. So that would be sort of an anabolic reaction. It's very insulin-like. Now there's the anti-insulin portion of this, and the anti-insulin would be the opposite of that, which would be more catabolic type reactions, where you would have enhanced lipolysis. Instead of lipogenesis, you'd have lipolysis, so the adipose tissue would start to break down fats. It would break down those free fatty acids and release them into the bloodstream so that most of the body tissues can then use fatty acids for their energy source. And then the glycerol would then be sent to the liver and then either can be broken down for energy or used for gluconeogenesis. All right, but then, so we'd see an increase in free fatty acid levels in the blood. And then you see a decreased glucose metabolism. So it's actually conserving or has a glucose sparing effect because it decreases the usage of glucose in the body by most of the tissues, with the exception of nervous tissue and red blood cells, because nervous tissue and red blood cells require glucose for their function. So this actually reduces other tissues from using glucose so that they'll use more fatty acids instead. And the glucose can then be spared or shunted to usage by the other tissues that can't use the fatty acids, like the brain or red blood cells, for example. So it has these dual effects by essentially enhancing protein synthesis in muscle and breaking down fats in adipose tissue. And so it can add a lot of what we call lean mass to somebody, which is why a lot of athletes would use it. Okay, but the sort of the caveat to this, especially for the athletes who might be taking growth hormone, is that elevated levels of growth hormone, what it can do is it has this effect here that I don't have written on here, that it actually increases the release of insulin from the pancreas. So they become hyperinsulinemic. So their insulin levels actually rise. Now that sounds counterintuitive because it seems like the insulin would sort of counter the effects of the anti-insulin effect. But what growth hormone does is it actually desensitizes these tissues to insulin. So it desensitizes them to insulin but raises the insulin levels. So this very much looks like a type 2 type diabetes effect, which again, if growth hormone is prolonged, could actually result in a diabetic type profile, where they have reduced insulin sensitivity and high levels of insulin. Now, this is sort of a complex factor here, is what we call the insulin-like growth factor 1. And IGF-1 is an intermediate of the growth hormone. So when growth hormone is released from the anterior pituitary, I'll draw it over here. I think it'll be easier to see it image-wise. So when growth hormone is released, okay, we have growth hormones which are released from the pituitary. It's going to act on the liver. And in the liver is going to then release IGF in response to the growth hormone. So it releases IGF-1. Now, growth hormone can also not only act on the liver, but it can act on other cells directly, namely things like skeletal muscles and adipose, and do the things that I just talked about, lipolysis and buildup of proteins. Right? But when it acts on the liver and produces IGF-1, IGF-1 can also act on skeletal muscle and adipose tissue, all right, and have very similar effects, which we're going to talk about in just a second. But can also act on other tissues as well, like the bone and cartilage and other tissues. Okay, and so it acts as an intermediate for that. And in fact, IGF-1 and growth hormone will then feedback inhibition. So we had our negative feedback to reduce the amount of growth hormone that is secreted. All right. Now, in terms of what IGF-1 actually does, it stimulates a very diverse population of tissues and cells. Generally, you'll see it increased during fasting, as you would with growth hormone in general. You'd see growth hormone levels rise during fasting. And again, that's to utilize things like fatty acids and reduce glucose usage to conserve it for the brain and red blood cells. It does promote protein synthesis at the muscle, so it works synergistically with growth hormone in that fashion. It has this interesting concentration-dependent effect on insulin sensitivity, though. So where growth hormone causes an increased secretion of insulin but reduces its sensitivity, IGF can actually inhibit insulin secretion. But at high enough concentrations, it can act like insulin itself and induce insulin-like effects like lipogenesis at the adipose tissue. So we have this sort of two effects of lipolysis and lipogenesis, which may be dependent on where the body fat is located and what effect is essentially predominant. So for instance, subcutaneous fat in the skin, might predominantly undergo lipolysis, whereas fat around the organs might undergo more lipogenesis. So IGF-1, what they found is IGF-1 is critical for what we call linear growth during puberty. So that's that increase in height that we get during growth. So that's that growth plate that we have in our bones that has cartilage there. And so it seems to be vital for that. And so you'll see an increase in growth hormone, and you'll need IGF in order for that linear growth to occur during puberty. So this over here, on the picture to the right, here these are the pygmies. So this is our average size male adults right here, and you can see that the stature of the pygmies here much smaller. And what they found is that they're not actually deficient in growth hormone, but that they actually have reduced amounts of IGF. And so a reduction in that IGF means that during that linear growth phase in puberty, they would have a stunted growth, which is what happens here. There's a deficiency in the IGF-1. And so that's to kind of illustrate the importance of that particular molecule. IGF-1, in addition to being released by the liver in abundance, can also be released locally by the tissues themselves. So what happens, it seems that growth hormone, not only does it have a direct action on tissues where it can induce changes, it can act on the liver and increase IGF-1, but it can also act on other peripheral tissues, and its action seems to be less direct there, where when it acts on these other tissues, it increases that tissue's production of IGF-1 locally. And then the IGF-1 that's produced there acts locally in a paracrine or autocrine type fashion, which enhances the actions or carries out the actions of growth and differentiation and so on. So to trigger growth hormone release, ultimately to grow the bone, to thicken it, remodeling it, primarily occurs during childhood and adolescence. And as an adult, what will trigger it is really one of the primary triggers is going to be hypoglycemia. So low blood sugar levels will increase growth hormone levels. And the opposite is true. So if you were to eat a meal with a lot of sugar in it, that would actually inhibit growth hormone release. Starvation. So starvation, again, sugar levels could be more depleted there. So this would actually help to utilize fatty acids during periods of starvation, as opposed to glucose. And it helps to keep the glucose levels higher in the blood, so it helps to stimulate gluconeogenesis. You would see, again, I told you that these hormones can be sort of phasic. And so under sort of basal conditions, you would see a peak in people during sleep. Within the first 2 hours of deep sleep is where you'll see a large peak in growth hormone. And then during exercise, usually during vigorous exercise, you can see another peak in growth hormone, or even after a protein meal. In fact, growth hormone seems to peak in response to specific amino acids. Stress can also increase growth hormone levels. Again, typically the idea is that it's going to increase glucose levels in order to help supply the body, which is under duress. Growth hormone levels will ultimately decline with age. And so what you see is that the peak is really in early adolescence after puberty, and it just declines steadily throughout the rest of your life. And that actually can contribute ultimately to the phenotype of aging and tissues and wrinkling, is this sort of lack of protein synthesis that is aided by growth hormone. And so this is from your notes, and this is kind of goes through stepwise what I just talked about, but I want to just quickly review with you guys. Is that here we have, starting at the top, here in the hypothalamus, all right, we have growth hormone inhibiting hormone, which is otherwise known as somatostatin, and growth hormone releasing hormone. So we have growth hormone releasing hormone, which can occur because, let's say, the person's hypoglycemic, or they're exercising, or they just had a high protein meal. That would increase GHRH. That would stimulate the anterior pituitary to release growth hormone, and growth hormone would then stimulate the liver, as well as skeletal muscle and adipose tissue directly. And so if it stimulates the skeletal muscle, as we talked, it'll increase amino acid uptake and protein synthesis. It'll decrease glucose uptake and utilization, and it increases lipolysis. And so this sort of joint effect is called anti-insulin, where we have decreased glucose uptake and lipolysis, all right, where this would be more of the insulin type effect, which is protein synthesis. So again, building more like lean mass. When growth hormone acts on the liver, again, it's going to produce this intermediate IGF. Another name for IGF was somatomedin C, which you can see written underneath there. IGF will also work on skeletal muscle and adipose tissue. And so over here, it's just written that it has the same effect on skeletal muscle. But on adipose tissue, here it's just written that it increases lipid synthesis, and that can happen in some of the adipose tissue. But it can also decrease or cause, or at least aid in lipolysis in certain conditions. Soft tissues over here increase collagen formation. On the skeleton, right, increases cartilage and growth. So during that linear growth spurt, and we talked about the pygmies, so it's needed for growth hormone. It's needed with growth hormone, and IGF to increase linear growth. Now, too much growth hormone at certain times will cause gigantism versus acromegaly. So let's take a look at that. So over here, this is growth hormone. Oh, excuse me. This is acromegaly, and this is gigantism. So in gigantism, you can see here the guy on the right here, all right, relative to say our average size individual to the left. So what happens is gigantism is really more defined as growth hormone levels that are high prior to the adolescent growth spurt. So what happens is the growth hormone then stimulates linear growth and can do so excessively. So you can get an individual who could be, 8 feet tall, and they're generally fairly proportional looking, as all the organs and everything else grows with it. However, in adulthood, after the growth plates have already closed, you could have acromegaly. Same idea, it's just too much growth hormone, but there's no linear growth, so no height. But the bones will continue to thicken. particularly bones of the face. And so you can see in the individual here, the bones of the jaw, for example, will get wide and start to protrude. In fact, it can get so big the teeth themselves can start to space out. You can kind of see bossing or increasing in bony deposition on the forehead. The nose and the ear cartilage can start to grow. Sometimes they'll complain like, the hats don't fit them anymore. Their teeth are starting to space out. He's showing his hands in this picture here because he may not be able to wear the same rings that he could wear before as his fingers have gotten bigger. They'll sometimes complain of carpal tunnel syndrome because as the bones thicken, it impinges that tunnel, and so they end up with weakness in their hands. As you impinge the median nerve that feeds the muscles of the palms of the hand. But not only does their bone and the facial structures and all that change, but internally their organs are also growing. Like their liver can get quite large. Their heart, for example, can get very big and ultimately could lead to things like heart failure and be problematic for that with the cardiovascular system. But additionally, based on the actions of growth hormone, the fact that it desensitizes tissues to insulin, they can become hyperinsulinemic and ultimately lead to complications of diabetes with prolonged levels. And ultimately, these things would be treatable. We could inhibit the growth hormone production, or if there was, say, an adenoma that's producing the growth hormone, we can remove the adenoma and hopefully curb the side effects of the too much growth hormone. So that's the end of today's topic. If you guys have any questions, please don't hesitate to email me. All right, I'll see you guys soon in class.